Good afternoon. Welcome to Grand Rounds today. Please remember to sign the attendance record if you could, and also please remember to fill out the program evaluations and also give us any ideas that you might have in regards to future speakers and future topics. Our topic today is we're going to review a problem that I'm seeing, it seems, more and more frequently, and it's pulmonary hypertension, and we have an expert in the field today. Speaker is Dr. Sif Hansdottir. She is a pulmonologist, an internist, and also boarded in critical care medicine. She currently is assistant professor of medicine in the Division of Pulmonary and Critical Care Medicine at the University of Iowa. She's the director of the Pulmonary Hypertension Program, and she's the director of the Respiratory Specialty Care Unit at the University of Iowa. And please join me in welcoming her today.
Thank you so much. It's my pleasure to be here. It's my 13th year in Iowa, but first time in Ames, so I'm really happy to be here. I'm going to start slowly because I'm told that people are going to be coming in the next few minutes, so talking very slowly. So for disclosures, so I am the principal investigator for several clinical trials that are sponsored by industry by these following companies: Actelion, Bayer, Gilead, Icaria, and United Therapeutics. I will not be talking about any brand medications or recommending any specific therapies. I have no other financial interest. I have no stock in any of these companies. And I'm not on anybody's speaker's bureau either. So today, I'm going to give you an overview of pulmonary hypertension, starting with the WHO clinical classification and why we classify pulmonary hypertension the way we do. I'm going to talk a little bit about the hemodynamics as well. Most of the talk is going to be on really making the diagnosis, and that's really a twofold problem. The first is, why does this particular patient have pulmonary hypertension? And then the second, how do you make the diagnosis of group 1 or pulmonary arterial hypertension? And what do you do if you make that diagnosis with regards of treatment? At the end, I'm going to have a few slides about pulmonary hypertension that's due to left heart disease. And the reason I wanted to sort of do at least a few slides on that is that it is the most common cause of pulmonary hypertension in the United States. So I'm going to get started here. So first, the WHO classifies pulmonary hypertension really into 5 different categories. And diseases are grouped together based on pathophysiology and similarities there, also because of how they present clinically. And then also, the 5 different groups are treated very, very differently, and that is really a key point that I want to get through to all of you today. So what are these WHO categories of pulmonary hypertension? So the first one is pulmonary arterial hypertension, which is going to be the focus of the talk today. This is the only group of pulmonary hypertension and the diseases that fall into this category that we treat with these specialized medications that have been developed over the last 20 years. Previously, this was labeled as primary pulmonary hypertension, but that term is not used anymore. Instead, we use the term idiopathic pulmonary arterial hypertension, which is really a diagnosis of exclusion when you looked at all diseases in the other categories. Other diseases that behave similarly to the idiopathic form have also been categorized into this first category, and that is people who have pulmonary hypertension that run in families. There are certain genetic disorders that are at increased risk of developing pulmonary hypertension. Pulmonary hypertension related to drugs and toxins, and in particular, these are stimulants like amphetamine, cocaine, and also weight loss medications like fen-phen. Connective tissue disease, fairly common, in particular scleroderma, lupus, and mixed connective tissue diseases. Patients who have liver disease and who do have portal hypertension also fall into this category. And then some congenital heart diseases as well. Schistosomiasis we don't see a whole lot of in Iowa. Okay, the second WHO group of pulmonary hypertension is pulmonary hypertension due to left heart disease. And considering the prevalence of heart disease, this is going to be the most common etiology for pulmonary hypertension. These people can have systolic dysfunction, diastolic dysfunction, or left-sided valvular heart disease like aortic stenosis or mitral regurgitation would be the most common ones. Third group of pulmonary hypertension, and the second most common, is pulmonary hypertension that is related to lung disease or sleep-disordered breathing, in particular patients who have hypoxia. And this can be really any type of lung disease, whether it's obstructive lung disease, restrictive lung disease, or any type of sleep-disordered breathing. 4 is chronic thromboembolic pulmonary hypertension, and that is pulmonary hypertension due to blood clot. And then I'm not talking about the patient who comes in acutely with acute massive pulmonary emboli. If the emboli burden is significant acutely, the patients are going to have pulmonary hypertension when you look at their echoes. Once the patient has been anticoagulated for 3 to 4 months, most of the time the pulmonary hypertension resolved. About 5% of people continue to have pulmonary hypertension, and those are the people who fall into the chronic thromboembolic form of pulmonary hypertension. Last, there's sort of a group of diseases that are not well understood but have been associated with the pulmonary hypertension, and that is certain hematological problems, systemic disorders like sarcoid, and sort of other more rare diseases. You might see something like fibrosing mediastinitis here in Iowa from histo. So that was the clinical classification of pulmonary hypertension and the 5 different categories. Moving on to the hemodynamics. For somebody to have pulmonary hypertension, it's defined as the pressure measured by a right heart catheterization, the mean pressure being more than 25 millimeters of mercury. Somebody who has that on right heart catheterization has pulmonary hypertension that could fall into any of the categories that I mentioned on the previous slide. Pulmonary hypertension can be, based on hemodynamics, further divided into 2 categories. That is precapillary. Precapillary as in precapillary with regards to the pulmonary vascular bed. These patients, in addition to having their mean pulmonary arterial pressure greater than 25, should have a wedge pressure as a measure of the left heart filling pressure that is within normal. Into this precapillary category of pulmonary hypertension fall categories 1, the pulmonary arterial hypertension, pulmonary hypertension due to lung disease, pulmonary hypertension due to clots, or the multifactorial one. All of them are going to look similarly on the right heart catheterization. Important point here being is that you can't do a right heart catheterization really to make the diagnosis of the underlying cause. All of these different categories are going to look the same hemodynamically. Post-capillary, what that basically means is that the left heart filling pressures are elevated. This gets transmitted into the pulmonary vascular bed. So when we measure the pressure in the pulmonary artery, they're going to be elevated. But these people, as a general rule, have a wedge pressure that is elevated. So making the diagnosis. So this is the diagnostic algorithm, and I'm clearly not going to go over that in detail, but sort of what it involves. There are some pivotal tests, and then how they contribute to the assessment. First of all, you're never going to make this diagnosis if there's not a clinical suspicion. So if you have somebody with dyspnea that you just can't really quite understand, you've ruled out the sort of major, more common things, asthma, COPD, heart disease, please think about pulmonary hypertension. I'm going to tell you a little bit how these patients might present. Early on in the disease process, a patient might have shortness of breath, in particular with exertion, and they feel weak and tired. These symptoms are obviously very nonspecific, And the first thing you think about is probably not going to be pulmonary hypertension. And that is why, unfortunately, oftentimes the diagnosis of pulmonary arterial hypertension or the group 1 pulmonary hypertension gets made fairly late. Later on, when the disease has progressed, people start having lightheadedness, in particular with exertion and even syncopal spell, which is a poor prognostic factor. Chest pain and palpitations, also symptoms of more end-stage disease. And ultimately, they're going to have right heart failure and the clinical findings that follow that. If you see somebody where you are taking a history and you're starting to think about pulmonary hypertension, I want to encourage you to start asking and thinking about the risk factors. So in your mind, you're already thinking about, oh, this patient could have pulmonary hypertension. I wonder which category they're going to fall into. On physical exam, again, early stage, you can see here a loud P2 when the pulmonic valve closes under pressure. Oftentimes, or these patients that have right ventricular hypertrophy may have a left parasternal heave. If you think about the anatomy of the heart, the right ventricle is sort of located anteriorly, and you put your hand on their chest, and you might actually feel the heave. Later on in the disease, their pulmonic valve starts to be leaky, and you can hear a diastolic murmur. You can hear oftentimes the holosystolic murmur of tricuspid regurgitation. And then clinical findings of right heart failure, like the JVD goes up. They may have a hepatonuclear reflux, lower extremity edema, and oftentimes these patients sort of feel just kind of bloated. It seems like volume sometimes tends to sort of start in their belly, and they may feel that even when they don't have much lower extremity edema. All evidence of right heart failure. A patient presenting to you with shortness of breath, pulmonary edema, and pleural effusions, that is more left heart failure. Even if they have pulmonary hypertension, then the bells go off in my head that, oh, this looks like a primarily a left heart problem or a group 2 pulmonary hypertension. So EKG in somebody with pulmonary arterial hypertension, again, right heart under stress. You can see here on this EKG that this patient, the QRS is negative in lead 1, so this patient has a right axis. And then if you pay attention here, the R waves are tall already in the precordial lead, and that's an indication of right ventricular hypertrophy. And then we're seeing the diffuse ST depressions here, which are just repolarization changes. This might be an X-ray, and this is from one of my patients, and oftentimes the X-ray is pretty normal unless you're focused in on this particular diagnosis. As I just mentioned, these patients generally don't have pulmonary edema. They don't have pleural effusions. What you might see is enlarged pulmonary arteries on the right and on the left. So back to the diagnostic algorithm, and after you sort of thought, well, this patient has pulmonary hypertension, usually the next thing is echocardiogram, and I'm going to have a few slides and talk about the echocardiogram. Before I move on, I want to just sort of quickly touch on other things that we do. Again, we're trying to find out which category of pulmonary hypertension this patient belongs to, because the treatment that we're going to offer to the patient is going to depend entirely on the underlying cause. So as a workup, we do ventilation perfusion scan. What we're looking for is the 4th group for chronic thromboembolic pulmonary emboli, and a VQ scan still is more sensitive than a pulmonary angiogram when you're looking for chronic clots. This is not the acute. This does not apply to patients with acute pulmonary emboli, but a patient that has had chronic clots. Pulmonary function testing, looking for lung diseases, overnight oximetry to screen for nocturnal hypoxemia, and if that is indicative of desaturations, we might get a polysomnogram to look for sleep disordered breathing. Laboratory testing that we do routinely, HAV, to screen for HIV testing, to screen for HIV, obviously, which falls into that WHO group 1 pulmonary hypertension that we tend to treat. ANA to screen for connective tissue diseases, and then liver function tests, kind of thinking, could the patient have portal hypertension? And also, as we're evaluating the patient, we assess their functional status. Most of the time, we do a 6-minute walk test, and the reason that becomes important is an important prognostic factor. I am going to talk next a little bit about echocardiograms and then about right heart catheterizations. So, echocardiogram is for me, treating patients with pulmonary hypertension is really my best friend and my worst enemy. It is non-invasive, easy to do, and oftentimes it's really helpful. You can look at, is the heart big? How is the heart functioning? Is there evidence of systolic dysfunction, diastolic dysfunction? You can pick up an echocardiogram if you are looking for some detailed findings, which oftentimes get missed unless you're really focused in on that. You can look for valvular heart disease. With pulmonary hypertension, we think about aortic stenosis and mitral regurgitation in particular. So very helpful to look for these things. And also, we are diagnosing patients with atrial septal defects actually fairly late in life, and this can cause pulmonary hypertension as well. And then on the echo, we can also look for a right to left shunt, either with our Dopplers or with a bubble study on their echo. So this is an echocardiogram from somebody that has end-stage pulmonary hypertension. And just for orientation, this is the right atrium, the right ventricle, and you can see that with the pressure volume overload on the right side, the poor left heart, the left heart chambers are squished down, and you can just see, looking at this, how the left side is going to be underfilled. When we are looking for pulmonary hypertension on echocardiogram, a cardiologist is going to estimate the pressure depending on the tricuspid regurgitation. One important thing is that when you're looking at echocardiograms is that for the most part, or mostly, you're going to have estimation of the systolic pressure, but not the mean pressure that we use for the definition. The reason that's important is that when we get concerned that somebody might have pulmonary hypertension on echocardiogram, we're thinking about systolic pressures that are greater than 35. So this is a envelope of tricuspid regurgitation, and basically to estimate the gradient across the tricuspid valve, we plug this the velocity of the tricuspid regurgitant. In this case, it's about 4.5. Square it and multiply by 4, and then you have to add the right atrial pressure as well, and that's sort of the estimation of your pulmonary systolic pressure. But it's an estimate. It's not a direct measurement, and there's multiple studies showing that echocardiogram can overestimate the pressure, in particularly when the pressures are high, and it can certainly underestimate the pressure when we don't have a good tricuspid envelope, or some people just don't have much tricuspid regurgitation at all, and in these people, you can't really estimate their pressures at all, and that doesn't mean that they don't have pulmonary hypertension. You have to look at the whole echocardiogram. What's the size of the right chambers and how are they functioning? Also, echocardiogram is not really good to see if there's elevated left heart filling pressure to indicate could this patient have group 2 pulmonary hypertension related to heart disease. Important point is that we never ever start somebody on pulmonary arterial hypertension specific therapy, which I haven't talked about yet, without a right heart catheterization. The echocardiogram has too many limitations, and it's too important to get the diagnosis right before we submit somebody to these types of therapies, which are expensive and can possibly be harmful if they're used for the wrong indication. Moving on to the right heart catheterization. it's essential to definitely make the diagnosis of pulmonary hypertension. And in particular, if you're thinking about pulmonary arterial hypertension, that you're going to use some of the specific therapies for. We can measure the left heart filling pressures with our wedge pressure, and sometimes, not infrequently, I have my cardiologist actually directly measure the LVEDP as well. The right heart catheterization is also helpful to look for left to right shunt, as opposed to the echocardiogram, where we can look at the right to left shunt, the catheterizations by measuring oxygen saturations at the different chambers of the heart, and if there's a significant step up or increase in saturations as we go through the right heart, that's an indication that oxygenated blood is going from the left to the right. In some patients with, in particular patients that appear to have idiopathic pulmonary arterial hypertension, we do a vasodilator challenge. And lastly, the catheterization is important for prognosis. In particular, if the pulmonary vascular resistance is very high, or the cardiac output is low, or the right atrial pressure is high, those are poor prognostic factors, and we will make treatment recommendations and select treatments based on these findings as well. So what information, again, do you get out of the right heart catheterization? So here we have a pulmonary arterial catheter in place. We get pressures of the right atrium, so normal being about -1 to +8, and in a patient with pulmonary arterial hypertension, the right atrial pressure can be normal or high, and the higher the pressure, the worse the patient is off. The pulmonary arterial pressure, we talked about that before. In order to have pulmonary hypertension of any type, you need to have a mean PA pressure that's more than 25. And then also, important pressure here is the wedge pressure. So you see a balloon here at the tip of the catheter. By inflating the catheter and sort of obstructing flow here through the pulmonary artery, then you measure the pressure here distally, and at the tip here, with the balloon up, you can get the wedge pressure, which is an estimation of the left heart filling pressure. If it's a precapillary process, including the group 1 pulmonary arterial hypertension, this should be in the normal range. What else do we get out of this right heart catheterization? Well, cardiac output, which can be estimated by either thermodilution or FIC. Another important prognostic factor, if we have somebody with a cardiac index less than 2, they are not likely to do well. Pulmonary vascular resistance, you can calculate out of the pressures and the cardiac output. The higher the pulmonary vascular resistance, the less likely the patient is to do well. And as a general rule, the precapillary etiology should have an elevated pulmonary vascular resistance as defined by more than 3 Wood units. But if it's a post-capillary or group 2 pulmonary hypertension, in the simplest case anyhow, the pulmonary vascular resistance is normal. Patients don't read the textbooks, and even the hemodynamics can be confusing and are not always exactly like this. But this is sort of a textbook case that I'm talking about. Even the right heart catheterization has many pitfalls. For example, somebody that has significant mitral regurgitation, it can be difficult to measure the wedge pressure because the V wave is going to be really high. Also, when looking at the wedge pressure, it's important to do it at the right time in the respiratory cycle, and in somebody that is not intubated, that's at the end expiration. And there's multiple studies that also say that the wedge pressure is not always accurate. And what I would say that think about the patient that you have and do the hemodynamics fit the clinical picture. If you have somebody that is 87 with the hypertension and diabetes, and really somebody that should have based on clinical risk factors, group 2 pulmonary hypertension, and the wedge pressure is normal, then you have to think about the patient as a whole, and oftentimes special maneuvers need to be done during the right heart catheterization to sort of elicit that the problem is really in the left side of the heart. Okay, now I'm going to move on and talk about WH, so group 1 pulmonary arterial hypertension, for which we had no therapies 20 years ago, and now we have multiple different options to choose from. I talked about this in the beginning. I just want to briefly go over it again in case somebody missed the first part. But these particular diseases fall into that first category of pulmonary hypertension where we use the specialized medications. Idiopathic pulmonary arterial hypertension, a diagnosis of exclusion. Other things that you might run into and you might want to ask your patient about when you're thinking about why they have pulmonary hypertension is, have they used stimulants, amphetamine, cocaine, or been prescribed weight loss medications like fen-phen? And that story can be 10 years ago, 15 years ago. So you really have to ask. They're probably not going to volunteer that information. Does your patient have scleroderma or lupus, HIV infection, again, portal hypertension, or congenital heart disease? And in the non-pediatric population, most commonly we're looking for atrial septal defects. The problem in these diseases and in this category of pulmonary hypertension, it starts in the pulmonary arterioles. And so the vessels become narrow, which results in increased resistance within the pulmonary vascular bed. The pressure goes up. The right heart needs to get the blood through the lungs. Thus, patients develop right heart failure and ultimately they die. So what is the prognosis? The prognosis of historically from a cohort from the 1980s, which was patients which at that time were considered to be primary pulmonary hypertension or idiopathic pulmonary hypertension. Without any of the specific therapies, the median survival was 2.8 years. That's pretty bad. That's actually worse than most cancers. We've made some progress, and I'm going to talk about that. So what happens? Why do people develop this pulmonary hypertension? As with probably most medical illnesses, it's a combination of things. There's probably a genetic factor. Most of the time, we don't know what that is. And then there's some environmental stimuli or the diseases that we have already mentioned. The first thing is probably endothelial injury. And I'm going to focus here on is that we know patients who have this type of pulmonary hypertension have increased endothelin-1, decreased nitric oxide, and decreased levels of prostacyclin. And we have based our therapy or developed our therapies based on these findings. This is going to result in vasoconstriction and increase in growth factors, remodeling of the pulmonary arteriolar vessel wall. So this nice little pulmonary artery is going to no longer look like this. And in the worst cases, it can be completely obliterated by smooth muscle and endothelial thickening. The abnormal flow can also result in thrombosis. So how do we treat those patients? Starting with the more general things, which sometimes maybe are a bit forgotten, but are very, very important. We teach our patients about the disease, low sodium and fluid restriction, like you would with anybody with any type of heart failure. We also make sure that the patient weighs themselves every day, and they have to call us if they gain more than X pounds. And we have somebody on call 24/7 that can take those phone calls. So a lot of these supportive therapies, they make sense. We've done them pretty much always, but they haven't been extensively studied in randomized trials. So the recommendations is based on expert opinion as opposed to more robust clinical studies. So using diuretics makes sense. If you have heart failure, you have too much volume, you give diuretics. Oxygen. We always assess our oxygen or oxygen levels at rest. We have them people exercise and also during sleep, because with pulmonary hypertension, hypoxia is going to be a pulmonary vascular vasoconstrictor, so we don't like our patients to be hypoxic if we can help it. How about Coumadin, anticoagulation? I get asked this question all the time. Not extensively studied. We believe that at least in the idiopathic group, it's going to be helpful. We aim our INR goal between 1.5 and 2.5, which is different from most of the other disorders you're going to be treating with Coumadin. If I have somebody with portal pulmonary hypertension, I never anticoagulate them. I think the risks of them, if they're going to have a variceal bleed, they're going to bleed out. And also patients with connective tissue disease, sometimes I anticoagulate them. If they're at fall risk, then really I don't think that the benefits outweigh the risk. Digoxin, very, very, very little data behind that. It's expert opinion, recommendation C. And then rehab is probably good for these patients. I don't start it until I get a good understanding on how severe the disease is, but most of the time I do recommend rehab to them at some point. Okay, now I'm going to go to these specialized therapies that have been present, or the first one was FDA approved in 1995. Again, like I mentioned when I talked about the pathophysiology, we have learned that in these patients, there's an imbalance between vasoconstrictors and vasodilators. So they have reduced levels of nitric oxide, reduced prostacyclin, and increased amounts of endothelin. So these pathways we have learned to target when we're treating these patients. Starting with the pathway that was first targeted, the prostacyclin. So in the next few slides, what we're going to be looking at is this pale yellow endothelial cell, and the sort of darker orange is a smooth muscle cell in a pulmonary arteriole. So prostacyclins get produced from arachidonic acid. They're produced in the endothelium, and prostacyclin stimulates adenylate cyclase to produce cyclic AMP, and cyclic AMP causes vasodilation. It inhibits the smooth muscle proliferation and inhibits platelet activation and may have some inotropic effects as well. When we treat with prostacyclin, basically, we're just given a compound that is similar to the endogenous prostacyclin, right here. So this is what we have in the prostacyclin category. We have epoprostenol, which was the first one FDA approved in 1995. Epoprostenol has a very short half-life, so I'm talking about seconds. It is given with a pump, such as this one, in a continuous infusion through a Hickman catheter. Following this, we got treprostinil, which is currently available in 3 forms: sub-Q, intravenous, and also inhaled. And then we have iloprost, which is also inhaled. What are the limitations of prostacyclins? The short half-life, extremely expensive, and then the main side effects are going to be headache, nausea, diarrhea, flushing, and jaw pain. All of the patients that are on intravenous therapy are going to have these side effects, guaranteed. And really our titration, up-titration of the medication depends on how the patient is tolerating the medication from a side effect standpoint. What other things? If you're on intravenous prostacyclin, we always get worried about infection. And if a patient with pulmonary hypertension that's sick enough to require infusion gets a systemic infection, that is usually pretty bad news. So we have them monitor their site very, very closely. With a sub-Q, most difficult problem to manage is site pain. And then with the inhaled, it's coughing. Moving on to the next category that we had available for treatment of these group 1 pulmonary arterial hypertension. Again, endothelial cell, smooth muscle cell. Patients that have pulmonary arterial hypertension have higher levels of endothelin. And what endothelin does, it binds to its receptor on the smooth muscle cell and causes vasoconstriction, proliferation of the smooth muscle cell, and fibroblast activation. Endothelin receptor antagonist block the receptor on the smooth muscle cell, sort of decreasing or obliterating the results of endothelin. We have two medications in this category, both are given orally, bosentan and ambrisentan. And the limitations here is cost. They're very expensive, nothing like prostacyclins, but still expensive. Side effects, liver function tests. With patients on bosentan, we have to get liver function tests every single month. If they bump their liver function test, sometimes we have to stop the medication. Any woman that is of childbearing potential needs to be on two different types of birth control, and we also get a pregnancy test every month because of it's so teratogenic. Edema we see very, very frequently, and then headaches. Moving on to the third and sort of most recently FDA-approved category for treatment of pulmonary arterial hypertension, and this is the types of treatment that you might be the most familiar one with, as these medications are used for erectile dysfunction, are on TV all the time. So here we're targeting the nitric oxide pathway. So what does nitric oxide do? It stimulates guanylate cyclase to produce cyclic GMP. It's like cyclic AMP, causes vasodilation, inhibits platelets, and probably inhibits smooth muscle proliferation. Cyclic GMP is broken down by phosphodiesterase, and the therapies that we use inhibit this phosphodiesterase 5, and thus decreasing the amount of cyclic GMP that's being broken down or eliminated from the body. So sildenafil, in pulmonary hypertension, it's called Revatio. In a different indication, it's called Viagra. And then tadalafil is, in our world, Atherca, it's the same as Cialis. So problems here, they're expensive, but out of the three different categories, they are the cheapest one. If you're going to prescribe sildenafil and tadalafil for pulmonary hypertension, it's going to be significantly more pricey than if you're going to prescribe it for erectile dysfunction. That's the way it goes. So side effects, one thing to remember, if somebody is on a PDE5 inhibitor and they come in with chest pain, you shouldn't just pop a nitroglycerin under their tongue. There's a black box warning there, can cause profound hypotension. Other common side effects are headaches and heartburn and flushing. Okay, so we've talked about treatments, and I just kind of want to step and kind of remind us all that these types of treatments are only FDA approved, have only been proven to be beneficial for the patients that fall into that WHO Group 1 pulmonary arterial hypertension category. Now that we have all this option and we get this patient that falls into this category, what do we pick? Well, it varies. First of all, we want to treat everybody who has symptoms. If somebody has a little bit of pulmonary hypertension but is completely asymptomatic, these patients haven't been studied. We don't really know that it's beneficial to treat them, but usually they haven't been diagnosed, so it's pretty much a non-issue. But which agent do we pick first? Depends on a lot of things. The more symptomatic the patient is, in general, we want to be more aggressive, and more aggressive, or most aggressive, being putting in a Hickman catheter, having the patient on a continuous prostacyclin infusion, which is kind of a big deal. The patient needs to be able to manage the catheter, mix the medication, never run out of the medication. Remember, epoprostenol has a half-life of seconds, and if somebody's on that particular medications and runs out, that can cause very significant rebound pulmonary hypertension. We also look at other prognostic factors, and then patient preference. There's not every patient that we have might be interested or willing in being on such an invasive therapy. And then other comorbidities. How about, should we start more than one at the same time? Answer to that question, I don't know, and nobody really knows, and that's being investigated. So here, I just wanted to mention these typical traditional risk factors where we want to be more aggressive. So if the patient has evidence of right heart failure, whether it's clinically or by echo, if they are progressing quickly, their symptoms are progressing quickly, we want to be more aggressive. The WHO functional class, it's confusing. Here I'm talking about how symptomatic the patient is. If the patient is functional class 4, which basically means that they're symptomatic at rest or have had syncopal episodes, then we might actually want to go straight to an intravenous therapy. We don't want to diagnose patients that late. We're hoping that we can actually find these patients earlier in the disease course, obviously. Functional capacity is very important. We want to be aggressive if the patient can walk less than 300 meters on the 6-minute walk. Keep in mind that a walk distance is affected by other things besides just the breathing, though. We know that NT-proBNP and BNP, they correlate with severity and prognosis, so we monitor those in our patients. If their BNP is very high, we might want to be more aggressive. And then the hemodynamics that I mentioned before, high rate atrial pressure, high pulmonary vascular resistance, or poor cardiac output, these patients tend to not do as well. These are the guidelines, and I think we sort of touch on most things here. And this is a very, very busy slide. Sort of just to summarize, a patient with pulmonary arterial hypertension, we think about the background therapies or supportive therapies with anticoagulation, diuretics, and oxygen. These are based on expert opinion, haven't been studied in any big randomized controlled trials. If a patient has pulmonary arterial hypertension and may benefit from pulmonary arterial hypertension specific therapies, such as those as I talked about, the guidelines are going to recommend expert referral to a referral center. And then in selected cases, we didn't talk about the vasoreactivity testing. There's a very small subgroup of patients that have idiopathic form that may benefit from just a calcium channel blocker. Then we get into the specific therapies, and basically what we pick depends on their functional class, that is their symptoms. Very symptomatic, we go for IV therapy. Just a little bit of symptoms, we probably start with oral therapy. Combining therapies, it makes sense to add a medication in one category to a medication in another category when we don't have the response that we'd like to see. These types of combination therapies are still under investigation with regards to when to add a therapy, which therapies go best together, those types of things. Talked about this. So with regards of combination therapy, because we don't know how to combine or how to combine or even if to combine, we want to get these patients into clinical trials whenever possible. And again, this is probably where you want to have this done in a program that is used to dealing with these patients on a regular basis. So I showed you earlier the prognosis in the 1980s, before we had any of these treatments, was the median survival of 2.8 years. This is a study that was published last year from the REVEAL registry, which was done in the United States. And median survival now is getting more closer to 6-7 years. So I think we have made progress with those therapies that we now have to offer. Okay. At the end, I wanted to mention pulmonary hypertension because of left heart disease. Again, the reason being because of the prevalence of heart disease being so high, this is going to be the most likely cause of pulmonary hypertension in any given patient, if you're just doing based on epidemiology. This can be patients who have mitral valve disease, aortic valve disease. If it's significant enough, you can usually pick it up on an echocardiogram. They can have heart failure, which can be systolic heart failure or heart failure with the reduced ejection fraction, which is also usually fairly easy to pick up on an echocardiogram. But it can also be because of heart failure with preserved ejection fraction or diastolic dysfunction, which is not as easy always to diagnose and gets missed, I think, very frequently. again, it can be difficult, especially if you're looking at an echocardiogram, to distinguish between pulmonary arterial hypertension and pulmonary hypertension due to heart failure with preserved ejection fraction. On echo, they're going to have normal systolic function. They're going to have no significant valvular heart disease. And even to make things more complicated is that if you have a patient with diastolic dysfunction that has been very aggressively diuresed, their wedge pressure can be upper normal, like 15, 16. And so even based on hemodynamics, it can be difficult to distinguish these patients. In those cases, we oftentimes do a fluid challenge or an exercise challenge during the right heart cath. But what other things clinically are helpful? We get back to what did you think before you did your right heart catheterization? If it's a patient that is older, they might be morbidly obese, they have diabetes, they have hypertension, your clinical picture suggests that this is somebody that seems to have significant enough risk factors to have something like diastolic dysfunction. Also, favor group 2 in a patient that has orthopnea or PND indicative of left heart failure. These patients shouldn't really have pulmonary edema or pleural effusions. That's another indication that this is coming from the left side of the heart. EKG, it can be difficult to sort of distinguish, but in sort of the pure form, we're thinking about right heart problem, right axis. If it's a left heart problem, we are more likely to see left axis and left ventricular hypertrophy. And sort of the similar things with echocardiogram. The treatment for this category of pulmonary hypertension is to treat the heart failure best we can and manage all the underlying risk factors. So treat their hypertension, treat their diabetes, and if there's something that can be fixed like a valve, then that should be considered as well. There have been trials looking at some of these specific therapies in these types of patients, and thus far they've been largely disappointing. So to take home from this talk today, so there are many clinical conditions that can lead to pulmonary hypertension. There's only a subset of patients that fall into that first category that we know benefit from these specialized therapies that have been developed over the last 20 years. For other categories in particular, when the pulmonary hypertension is due to a left heart problem or a lung disease or sleep disordered breathing, the therapy is to manage the underlying cause the best we can, make sure the patient is oxygenated at all times, manage their heart failure. That is really what we have for these patients at this time. I didn't mention that patients who develop chronic thromboembolic pulmonary hypertension, or the fourth category, they may benefit from a thromboendarterectomy, major surgery done on bypass, only in a few selected centers in the US. We sent these patients to San Diego from Iowa, or from Iowa City. Lastly, because the treatment is so different, we have to do our homework really, really well with regards to what are the risk factors and do an extensive evaluation with regarding looking for different underlying etiologies on all of the patients. So with that, I thank you all for inviting me to come today, and if you have any questions.
Sif, of those, all the patients you see that have type 1 primary arterial pulmonary hypertension, what percentage do you actually find an underlying etiology, i.e., what percentage aren't thrown in the idiopathic category?
So, so the two most common one would be idiopathic or the connective tissue diseases. Less than half, I'm going to say, is going to be idiopathic. If you group everything together, then connective tissue disease would probably be, or would be number one, and then idiopathic, and then liver disease. Worldwide, though, Jamie, is that schistosomiasis, well, we don't see that in the U.S.
Is the mechanism of the fen-phen injury pulmonary hypertension leading to valve disease?
No, it's not the valve disease. So it's not, these patients do not have to have valvular heart disease to develop pulmonary hypertension. It does lead to intrinsic pulmonary arterial or vasculopathy.
And that in turn leads to the valve disease?
Does it lead to valve disease?
Yeah, can it? Pulmonary hypertension, it leads to leakiness, yeah?
Yeah, I mean, the thing is that as people develop right heart failure, the right heart gets bigger, then the tricuspid valve becomes regurgitant, and the pulmonic valve can become incompetent, if that's what you're referring to. Yes, so that way, yes.
Can I ask what drugs you're using during the right heart cath as a challenge? Like, are you using a Flolan or something else?
So we use inhaled nitric oxide in our center. I like it. It's of them all, it's the most expensive, but it's short acting, and I think has the least chance of having things go badly. And if things go badly, it's short acting. We had previously used adenosine. That's yeah. So I'd say most centers are using nitric oxide or adenosine.
Was it ever determined what percentage of the people who took fen-phen wound up with endothelial damage? Was it essentially everyone?
No, it's a minority of patients. I can't quote you an exact number. I'm not sure that we know the answer to that question, but I'd say a minority. And yet it's one of those things, and we don't understand why one person using fen-phen would develop pulmonary hypertension and another one doesn't. Probably a interaction between that hit or that stimuli and then some genetic disposition that we don't know. Thank you.